Okay, let's dive deep into the source material you've shared with us today, focusing on central retinal artery occlusion, or CRAO. This isn't just a summary. Our mission is to meticulously unpack this text, extracting every vital piece of information, the underlying science, the clinical picture, the treatment strategies, and the evidence supporting them, specifically tailored for specialist clinicians like you. We're aiming for a truly comprehensive exploration of what this source presents.
That's right. What's fascinating here is how this source takes a complex emergent ophthalmic condition that has historically had a very poor prognosis and synthesizes the current understanding and proposed management pathways. It really lays out the clinical challenge and presents, well, a potentially game-changing approach.
And that potential is what makes this dive so compelling. We're going to structure this by first establishing the foundation, the anatomy, and the devastating why behind CRA. Then we'll move into identifying these patients, the key findings you'll look for on examination, and the crucial diagnostic workup to uncover underlying causes. We'll spend significant time on the core of the source's message, the management strategies, particularly the detailed algorithms for hyperbaric oxygen therapy, which the source positions as the standout treatment.
Right. The HBO part is really central here.
Exactly. Finally, we'll scrutinize the evidence presented, look at follow-up care, consider the cost implications discussed, and pull out the key takeaways the authors emphasize.
So by the end of this deep dive, our goal is for you to have a robust, detailed understanding of central retinal artery occlusion, grounded explicitly in this source material. This should help you navigate the emergent presentation and complex management decisions for these time-sensitive cases in your own practice. Background.
Let's start with the background the source provides. Central retinal artery occlusion is described as a relatively rare condition, yes, but critically, an emergent one affecting the eye.
Precisely. And the hallmark, the symptom that brings these patients to your attention with extreme urgency is sudden, painless vision loss.
Painless is key there.
Absolutely. The source emphasizes that this vision loss is typically dramatic, meaning severe and, alarmingly, permanent in many cases if untreated or managed with less effective historical methods. The prognosis for visual recovery in general is considered poor, according to the source.
And the source points to certain patient populations who are particularly at risk for developing a CRAO. It specifically lists those with conditions like giant cell arteritis, a significant atherosclerosis, hardening of the arteries, and thromboembolic disease, where clots travel from elsewhere in the body. These are the systemic red flags that should prompt suspicion.
Reflecting on the history of managing this condition, the source notes that a wide variety of treatment modalities have been attempted over the last, 100 years?
A long time.
A very long time. But, and this is a critical point from the source, these historical attempts are described as having had little success. The notable exception, the therapy presented here as having potential efficacy, is hyperbaric oxygen therapy, or HBO2. Rationale.
Okay, let's get into the why, the fundamental rationale based on the anatomy and physiology described. The source explains that the arterial blood supply to the eye originates from the ophthalmic artery,
Right.
which is a branch of the cavernous portion of the internal carotid artery.
And this ophthalmic artery gives off branches that supply various structures. Some branches feed the orbital structures surrounding the globe, listed specifically as the lacrimal, supraorbital, ethmoidals, medial palpebral, frontal, and dorsal nasal arteries. Others supply the tissues of the globe itself, crucial for vision, the posterior ciliary arteries, both short and long, and the anterior ciliary arteries.
The central retinal artery, the vessel central to our discussion, is particularly vital because it supplies the substance of the optic nerve. More importantly, for the acute vision loss in CRAO, it serves the inner layers of the retina through its many branches.
In contrast, the long posterior ciliary arteries primarily supply the choroid, the vascular layer behind the retina. They also contribute blood flow to the outer layers of the retina.
Different supply systems, essentially.
Exactly. The source details the numbers approximately 20 short posterior ciliary arteries and usually 2 long ones, all originating from the ophthalmic artery. These posterior ciliary vessels supply the entire uveal tract, the ciliary arteries, the sclera, the margin of the cornea, and the adjacent conjunctiva. It's a rich, albeit distinct, vascular network from the central retinal artery circulation.
Given this complex setup, the visual signs and symptoms you see in vascular occlusive diseases of the retina depend on several factors outlined by the source. Which specific vessel is occluded, the degree of the occlusion, like, is it a total block or partial?
Right, the location.
the exact location of the occlusion within the vessel tree, and importantly, the presence or absence of a ciliaretinal artery.
A ciliaretinal artery is an anatomical variant present in about 15 to 30% of individuals, according to the source. It's key because if present, it's part of the ciliary arterial supply, not the retinal. This means it can bypass a central retinal artery occlusion.
And this structural difference has a direct clinical impact. The ciliaretinal artery supplies the area of the retina around the macula, the central vision area. So the source highlights that if a ciliaretinal artery is present and functional, central vision may actually be preserved even in the face of a complete central retinal artery occlusion.
Yeah, that's a critical prognostic point.
Absolutely. A crucial point for patient counseling and determining potential visual prognosis.
In a classic central retinal artery occlusion, the inner retinal layers, the ganglion cell layer and the internuclear layer, which are normally supplied by the retinal circulation, lose viability due to lack of oxygen. This loss of viability is what causes the profound vision loss.
But here's where the physiological rationale for oxygen therapy comes in. The source explains there's a possibility for these ischemic inner retinal layers to potentially get oxygen via diffusion from the choroidal circulation, which is still supplied by the posterior ciliary arteries. This diffusion might be sufficient to maintain the viability of the inner retinal layers if the individual is exposed to elevated partial pressures of oxygen.
Animal models, cited in the source, lend support to this concept. These studies showed that choroidal vessels could supply enough oxygen to the inner retina to maintain ganglion cell viability, even after the retinal vessels were completely obliterated.
And the source provides the numbers behind the choroid's contribution. Normally, under regular air breathing normoxia, the retina gets about 60% of its oxygen from the choroidal circulation.
But under hyperoxic conditions breathing high concentrations of oxygen, especially under pressure, the source states the choroid is capable of supplying 100% of the retina's oxygen needs. This physiological capability under high oxygen is the core basis for why oxygen therapy is proposed as a treatment.
When considering treating CRAO with supplemental oxygen, the source outlines 4 key factors influencing the outcome. First, therapy must start before the retinal tissue is irreparably damaged.
Time sensitivity again.
Absolutely. Underscores the extreme time sensitivity of the condition.
Second, the degree of the occlusion isn't always complete. A partial occlusion might allow some limited flow, and the source suggests this variation could explain why some patients respond to oxygen. Maximizing oxygen supply might capitalize on any residual flow.
Third, some patients may not respond to hyperbaric oxygen even if treated early. This could happen if the occlusion is higher up, affecting the ophthalmic artery itself.
Because if the ophthalmic artery is blocked, the posterior ciliary vessels supplying the choroid are also blocked. With no choroidal blood supply, there's no collateral circulation to provide oxygen to the inner retina via diffusion, even under high oxygen pressures. So HBO wouldn't work in that scenario.
And fourth, the patient must receive an adequate partial pressure of oxygen and maintain it until circulation is restored.
Restoration of circulation typically happens via natural recanalization, which the source says usually occurs within 72 hours. However, the source also notes that recanalization in retinal vessels after CRA occurs in relatively few cases reported in the literature.
And even when spontaneous recanalization does happen, reperfusion leads to vision improvement in only a minority of cases referenced. This highlights that reperfusion alone isn't enough if irreversible damage has already occurred during the ischemic period.
The retina's vulnerability to ischemia is extreme due to its incredibly high metabolic rate. The source quantifies this, stating the retina has the highest oxygen consumption rate of any organ, 13 milliliters per 100 grams per minute.
Wow.
Yeah, it's remarkable. This sensitivity is why CRO is so devastating and requires such rapid intervention.
And finally, the source emphasizes that for supplemental oxygen to be effective, it must continue until flow through the retinal artery is restored to a level sufficient to maintain inner retinal viability under normoxic conditions when the patient is breathing regular air again.
Right, so the duration of therapy depends on achieving stable, natural perfusion.
We've just covered the critical anatomy of the eye's blood supply, how CRAO leads to devastating vision loss by starving the highly metabolic inner retina of oxygen, and the physiological basis for oxygen therapy, the potential for the choroid to supply 100% of the retina's oxygen needs under hyperoxic conditions, potentially preserving tissue in the ischemic penumbra. We discussed the key factors influencing treatment outcomes, including the absolute necessity of timely intervention, the location and degree of the occlusion, and maintaining adequate oxygen until flow is restored, while also noting that spontaneous recanalization and vision improvement are unfortunately infrequent based on this source. Patient selection criteria.
Moving on to patient selection, the source lays out the classic presentation of CRAO, sudden painless loss of vision.
The severity can vary significantly, from light perception only to being able to count fingers. The source points out that if vision is completely lost, no light perception, it might indicate a more severe, extensive occlusion, specifically an ophthalmic artery occlusion.
Which, as we discussed, is critical because it also blocks the choroidal supply, eliminating that potential collateral oxygen source for the inner retina, even with hyperbaric therapy.
Exactly.
On the other hand, if central visual acuity is relatively spared, that strongly suggests the presence of a ciliaretinal artery preserving macular function.
You'd confirm these suspicions with a dilated fundoscopic exam, looking for signs consistent with CRAO and specifically identifying a ciliaretinal artery if central vision is spared.
On fundoscopy, the classic findings described are a pale, yellowish-white appearing retina due to ischemia or necrosis of the inner layers. A cherry red spot may also develop in the macula, although the source notes it's not always present.
Right.
And importantly, the source states the presence of a cherry red spot is considered a poor prognostic indicator.
Other exam findings can include an afferent pupillary defect, signaling optic nerve pathway damage, and box scarring of arterioles, the segmented appearance of blood flow indicating very slow or interrupted circulation.
Now, for treatment consideration, the source makes a crucial point. Patients presenting within 24 hours of symptom onset should be considered for hyperbaric oxygen therapy. This 24-hour mark is presented as a key time window.
Okay, so 24 hours is the target.
That's a primary window highlighted here. While rare case reports of improvement beyond this window exist in the literature reviewed, the majority of cases did not respond when treated past 24 hours, reinforcing the urgency.
The source also mentions that patients with branch retinal artery occlusion, BRAO, has shown some benefit from hyperbaric oxygen therapy, referencing data in Table 1.
However, despite the physiological rationale potentially applying, the source explicitly states there's insufficient data in the literature to support routine hyperbaric oxygen therapy for central retinal vein occlusions.
Ah, important distinction.
Very important. It makes that distinction clear based on the current evidence it reviewed.
We've just covered the classic presentation of CRAO, sudden painless vision loss, and how to assess severity and look for key features like preserved central vision hinting at a ciliaretinal artery, or no light perception suggesting ophthalmic artery involvement. We detailed the hallmark fundoscopic findings: pale retina, potential cherry red spot, a poor prognostic sign, afferent pupillary defect, and box scarring. Crucially, we established the 24-hour window from symptom onset as the primary time form for considering hyperbaric oxygen therapy, noting the limited efficacy reported beyond this based on the literature here, and clarified that HbO2 is not routinely recommended for central retinal vein occlusion, according to the source. Clinical management.
Let's move into the clinical management pathway outlined in the source. Patients presenting with sudden, painless vision loss suggestive of CRAO should be triaged with the highest urgency as an emergent condition.
This emergency status is due to the critical need for immediate vision documentation and rapid initiation of management, because, as we know, time is vision. Visual acuity must be documented as soon as possible upon presentation. If vision is decreased and doesn't improve with a pinhole test, suspicion for CRAO is high.
Given that suspicion, the source directs the emergency physician to immediately perform a fundoscopic exam, using dilation if feasible and not contraindicated.
Okay, but what about contraindications?
The contraindications to dilation listed here are specific: flashes or floaters, preceding vision loss, pain, a history of recent trauma, or being younger than 40. These signs might point towards alternative diagnoses like retinal detachment or vitreous hemorrhage.
Got it. An ophthalmologist must be consulted emergently for suspected CRAO. And here's a vital directive from the source: treatment with supplemental oxygen should not be delayed while waiting for their arrival. Immediate oxygen is key.
Absolutely critical. In centers managing CRAO as part of stroke care, neurology should also be consulted. The source ideally recommends admission under a stroke protocol with combined ophthalmology and neurology management, emphasizing the multidisciplinary approach needed for both the ocular event and the underlying systemic risk.
The source mentions traditional adjunctive measures. Measuring and treating elevated intraocular pressure has been done based on anecdotal reports suggesting it might help dislodge a clot. Similarly, ocular massage is also anecdotally reported as occasionally dislodging clots.
Anecdotal being the key word there.
Exactly. The source frames these as anecdotal, not strongly evidence-based primary treatments.
A comprehensive diagnostic workup is essential, but done in parallel, not delaying oxygen. This workup screens for predisposing conditions and includes complete blood count, ESR, and CRP, crucial for giant cell arteritis screening, coagulation panel, antiphospholipid antibody panel, lipid panel, EKG, carotid ultrasound.
That's quite a list.
It is. And also MRI, which can reveal incidental brain infarcts. Fluorescein angiography were available to visualize retinal flow, and echocardiography for cardiac emboli source.
The source highlights the importance of this workup with compelling data. Previously undiagnosed vascular risk factors were found in 78% of CRAO patients in one study, and a striking 32% had acute or subacute incidental brain infarcts on MRI in another study.
Wow, 32%.
Yeah, it clearly shows the high systemic risk these patients carry, reinforcing the need for admission under a stroke protocol.
But, to reiterate, hyperbaric oxygen therapy absolutely should not be delayed to complete this extensive workup. Get the oxygen started while the workup proceeds.
For suspected arteritic CRAO, likely giant cell arteritis, emergent intravenous corticosteroids are required. The source clarifies that even in these cases, hyperbaric oxygen therapy should still be undertaken alongside steroid treatment, addressing both inflammation and ischemia.
Right, do both. Management, even if symptom onset is within 24 hours or less, should be guided by findings and a specific algorithm, which the source presents in Figure 2. This algorithm directs oxygen delivery titrated to patient response.
We've just outlined the emergent clinical management of CRAO, starting with immediate visual acuity, fundoscopy, and urgent consults with ophthalmology and potentially neurology as part of a stroke protocol. We covered the extensive systemic workup to find underlying causes, stressing it shouldn't delay emergent treatment, and the specific need for emergent steroids in suspected arteritic cases in addition to oxygen. Now let's really break down the sequential oxygen therapy algorithm presented in the source.
Okay, let's walk step by step through the central retinal artery occlusion treatment algorithm presented in Figure 2 of this source. It's a flow diagram guiding oxygen therapy based on response.
It starts at the very beginning, the immediate step in the emergency setting with surface ORO at highest FiO.
Right.
This means delivering 100% oxygen via a non-rebreather mask at 1 atmosphere, essentially standard high-flow oxygen.
The algorithm then asks the question, no response to surface oxygen. If there's no satisfactory improvement seen, the next step is compress to 2 ATA.
Compress to 2 ATA means initiating hyperbaric oxygen therapy at a pressure of 2 atmospheres absolute, equivalent to 202.65 kilopascals.
The duration specified for this initial HBO treatment at 2 ATA within the algorithm is TX for 90 minutes, so a 90-minute treatment session.
After that first 90-minute session at 2 ATA, the algorithm prompts for the response, marked vision improvement.
If the answer is yes to marked vision improvement, the algorithm directs back to continue to titrate OHBO ophthalmology referral. This indicates ongoing oxygen therapy, likely further HBO sessions tailored to the response under continued ophthalmology care.
If the answer is no response after the 90-minute treatment at 2 ATA, the algorithm moves to the next level. Compress to 2.4 ATA.
Compress to 2.4 ATA increases the pressure to 2.4 atmospheres absolute, or 243.18 kilopascals.
If there is still no response to treatment at 2.4 ATA, the algorithm escalates further to perform USNTT6 60S stubit.
Perform USNTT6 60S SO refers to the U.S. Navy Treatment Table 6 protocol, which involves compression to a depth equivalent to 60 feet of seawater.
Okay.
This corresponds to a pressure of 2.8 atmospheres absolute, or 283.71 kilopascals.
Following the U.S. Navy Treatment Table 6, the algorithm again asks, vision improvement.
If yes to vision improvement with USNTT6 2.8 ATA, the algorithm points to continue to titrate OVFAO's ophthalmology referral. This again means continued oxygen therapy and ophthalmology management, adjusting treatment based on the observed improvement.
If the answer is no to vision improvement with USNTT6 2.8 ATA, the final step in the algorithm is ophthalmology referral, option HBO. This suggests continued ophthalmology management and that further HBO therapy is still an option, though the algorithm itself doesn't specify the nature of these additional options.
Now, the source also provides a more detailed step-by-step written description of the initial management alongside this algorithm, and it introduces some nuances and potential points of comparison or even subtle discrepancy that are important to note.
Right, let's look at those. Step 1 in this written description aligns perfectly. Deliver oxygen immediately at 1 ATA at the highest possible ADO. Simple enough.
Step 2 offers an alternative pathway for initial responders. If vision improves significantly with normobaric oxygen within 15 minutes, the patient should be admitted and given intermittent normobaric oxygen.
And how does that intermittent regimen work?
It's detailed. 15 minutes of 100% oxygen every hour, alternating with 45 minutes of breathing room air. The source explicitly states this alternating is to mitigate oxygen toxicity. Visual acuity is checked at the end of each air period. This continues until fluorescein angiography shows artery patency, or up to 96 hours, or if vision is stable on room air for 2 hours.
Step 3 in this written description says, if vision improves significantly at 1 ATA oxygen, but no response within the first 15 minutes, refer for emergent hyperbaric oxygen therapy. Now, this phrasing is a little tricky compared to step 2. Let's interpret this as applying if there's some initial improvement on normobaric oxygen, but not the marked significant improvement within 15 minutes that would trigger the intermittent normobaric pathway alone. In that case, HBO is the next step. Does that sound right?
Yes, that seems the most logical interpretation given the flow. The description for this initial HBO treatment in step 3 is, hyperbaric oxygen should be delivered for 90 minutes at the depth of return of vision, with a maximum of a USNTT6 protocol for the first treatment. This is where we see a subtle difference from the algorithm.
How so?
The algorithm had fixed pressures, 2.4, 2.8 ATA. This description suggests the initial HBO depth might be titrated upwards during compression until vision returns, with USNTT6, 2.8 ATA, being the maximum for that first session. We need to present both these approaches from the source, the fixed pressure algorithm sequence, and the titration to response idea in the description.
Got it. Step 4 matches the algorithm again. Compress to 2 ATA on 100% oxygen.
Step 5 repeats that adjunctive therapies shouldn't delay HBO and directs to remain at this depth, 2 ATA, for 90 minutes. It adds that air breaks at 2 ATA may not be necessary because oxygen toxicity seizures are lower here than at 2.4 ATA.
Interesting point about the air breaks.
It is. It's a specific detail presented, even though air breaks are generally recommended elsewhere to reduce toxicity risk.
Step 6. If vision fails to improve significantly at 2 ATA by the first air breathing period, or 30 minutes, compress to 2.4 ATA. This suggests checking for improvement relatively early into the 2 ATA session, maybe within 30 mins or around the first air break if they're used, before escalating pressure to 2.4 ATA.
Right. And at 2.4 ATA, if vision does improve significantly, the description in step 6 says to conduct a U.S. Navy treatment table 9 protocol. Note that this is a different treatment table, USNTT9, mentioned for improvement at 2.4 ATA compared to the algorithm which moves past 2.4 ATA to USNTT6 if there's no improvement.
Okay, so another potential discrepancy. Algorithm says 2 minus 2.4 and is 2.8 USNTT6 if no response. Description suggests 2 ATA if no good response, try 2.4 ATA. If response at 2.4, use USNTT9.
Exactly. It's important to note these variations presented in the source.
Step 7 continues the escalation. If vision does not improve significantly at 2.4 ATA, compress to 2.8 ATA. This aligns with the algorithm's step to USNTT6. It says, if no improvement occurs after the first 20-minute breathing period, consider conducting a U.S. Navy treatment table 6.
This step then provides options if there's no response to the initial USNTT6. Discontinue treatment, continue intermittent normobaric oxygen from step 2, or give 2 additional treatments for 90 minutes at 2.8 ATA with air breaks twice daily. The source explicitly states we do not recommend this strategy, meaning stopping after the first treatment, strongly favoring multiple treatments.
And there's data to back that up.
Yes, this preference is backed up by a case series cited. In 10 patients, 2 improved after the first treatment, but 2 didn't improve until the third, 2 until the fourth, and 2 until the 8th treatment.
8th treatment, wow.
Yeah. This data powerfully illustrates the potential benefit of continuing HPOs even without immediate response. The source adds a note that the optimal pressure for repeat treatments in those initially unresponsive is unknown, but suggests 2.4 ATA for 90 minutes with air breaks is reasonable. This adds yet another pressure. 2.4 ATA is an option for repeat treatments, distinct from the twice-daily 2.8 ATA mentioned earlier as an option after an initial failed USNTT6. These variations in described protocols are important for a clinician evaluating the source.
Step 8 covers follow-up. If vision returns during HBOs, Inpatient monitoring and intermittent supplemental oxygen are considered. Ongoing retina specialist monitoring is needed.
Right. Recovery during HPO signals retinal viability, but the source cautions this must be weighed against the ischemic time before treatment.
Yep.
Patients with recovery need frequent visual status monitoring after completing HPOs.
We've just meticulously detailed the CRAO management algorithms and descriptions presented in the source. We started with immediate normobaric oxygen, then walked through the escalating hyperbaric pressures, 2 ATA, 2.4 ATA, 2.8 ATO, and TT6, in the Figure 2 algorithm, noting durations and response-based steps. We layered in the nuances from the written steps, including intermittent normobaric oxygen for initial responders, titrating initial HbO2 depth to vision return, and the introduction of US NTT9. We highlighted the explicit recommendation for multiple treatments even if the initial one is unsuccessful, supported by case series data showing delayed responses, and noted the variations presented within the source regarding optimal pressure for repeat treatments, 2.4 ATA versus 2.8 ATA. We concluded with the immediate follow-up after treatment completion, follow-up management Figure 3 detail.
Let's transition now to the recommended follow-up management after initial HPO therapy, as laid out in Figure 3. This algorithm specifically applies to patients who did show improvement after their initial hyperbaric treatment.
The algorithm starts with FU-MGT for CRAO improved after initial HBO RX. The first step post-treatment is crucial. Check vision 15 minutes on room air at HBO site. This tests the stability of the vision gain off the high oxygen environment.
The critical question posed next is, does vision worsen without supplemental ORO? This checks if the recovered vision is dependent on continued oxygen support.
If the answer is yes, vision worsens off oxygen, the algorithm directs to repeat HBO retreatment. This means repeat hyperbaric sessions are necessary if the gain wasn't stable on room air.
If the answer is no, vision does not worsen without supplemental oxygen, the algorithm suggests DC after 24 hours. Instruct patient to return immediately if vision loss recurs.
Okay, so is stable, potentially discharge after observation.
Exactly, but with strict instructions about recurrence.
Let's follow the path for recurrence. If vision worsens off oxygen, leading to repeat HBO retreatment, the algorithm presents a path labeled vision loss recurs. This is for the scenario where, despite repeating HBO, the vision loss comes back.
If vision loss recurs after repeat HBO, the algorithm directs to a higher level of care. Admit to hospitals of impending stroke. Check vision hourly with speed on room air. Urgent ophthalmology consult.
That sounds serious. Impending stroke evaluation.
Yes, it elevates the urgency, involves a full stroke evaluation, close monitoring, and urgent ophthalmology reassessment.
Looking at the path from repeat HBO treatment for ongoing therapy, there's a box detailing a combined regimen. 100% normobaric ORO 15 minutes each hour, 45-minute room air queue, also bid HBO's treatments. This outlines continuous intermittent normobaric oxygen plus twice-daily hyperbaric oxygen sessions for patients requiring repeat treatment.
This combined regimen is continued, as per the algorithm, for 96 hours until improved vision is sustained or until CRA recanalizes on IVFA. This provides duration and specific endpoints for this intensive phase of follow-up therapy, using intravenous fluorescein angiography to confirm arterial patency.
Finally, going back to the admit to hospital path, if improvement is sustained during that admission period, improvement sustained, the arrow points back to the discharge box.
Right.
This means if admitted for recurrence and they stabilize, they follow the same discharge protocol. Discharge after 24 hours with instructions to return immediately if vision loss recurs.
We've just detailed the recommended follow-up algorithm from Figure 3 for CRAO patients who improved with initial HBO. This involves checking vision off oxygen for stability, repeating HBO if vision worsens, and escalating to hospital admission for stroke evaluation with close monitoring and urgent ophthalmology if vision loss recurs despite repeat treatment. We also outlined the combined intermittent normobaric and twice-daily HBO regulature for continued therapy until sustained improvement or confirmed recanalization on fluorescein angiography for up to 96 hours. Notes.
Let's quickly highlight some important notes from the source. The source points out that the retina may not tolerate periods of ischemia lasting longer than 90 minutes. This provides a potential biological limit for tissue viability and underscores the extreme time sensitivity we've discussed.
The source also notes that cases of relapse of vision loss and subsequent blindness after discharge have been reported in the literature. This confirms the risk of recurrence, even after apparently successful initial treatment.
This is why the source emphasizes that patients who experience relapse after discharge must be explicitly instructed to return immediately for supplemental oxygen therapy if vision loss recurs.
Critical discharge instruction.
Absolutely. Reinforces the crucial discharge advice given in the follow-up algorithm.
The source identifies one key exception to the standard CRAO management, including HBO. This is CRAO resulting from air gas embolism, or AGE.
In cases of CRA caused by AGE, the source states that the recommended treatment regimen for AGE should be followed. This typically involves specific hyperbaric oxygen protocols designed for gas embolism, often including at least a U.S. Navy treatment table 6.
Furthermore, the source lists specific patient populations for whom hyperbaric oxygen therapy should always be undertaken if they present with CRAO. Those with a history of decompression illness, recent hemodialysis, or recent general anesthesia.
Why those groups specifically?
These are situations where occult gas embolism is a higher probability, and HBO is the definitive treatment for that underlying cause, potentially mandating its use even if the time window for ischemic CRAO might otherwise seem less favorable, although the source doesn't explicitly state an exception to the time window for these specific groups. Evidence-based review.
Now let's critically examine the evidence base for CRAO treatment as presented in this source. The source lists the potential culprits behind retinal arterial occlusive disease: atherosclerosis-related thrombus, embolism from elsewhere, vasospasm, and giant cell arteritis. Identifying these underlying causes is crucial as part of the management.
The source firmly reiterates that CRAO with significant visual loss is an ophthalmic emergency demanding immediate action.
And the fundamental goal of treatment, based on the physiology we discussed, is to rapidly supply oxygen to the ischemic retina at a partial pressure sufficient to keep it alive, while spontaneous or medically assisted restoration of blood flow occurs.
The source cites animal models of retinal injury treated with experimental CRAO and HBO. These studies provide biological support, showing a reduction in apoptosis. Programmed death cell loss went from 58% down to 30% with HBO treatment and maintenance of retinal thickness.
So some basic science support there.
Exactly. These findings suggest HBO can preserve retinal tissue during ischemia in animal models.
Historically, traditional CRAO therapies aim to dislodge the clot downstream, lower intraocular pressure, or cause vasodilation. These include ocular massage, anterior chamber paracentesis, pressure-lowering drops, systemic vasodilators, and oral diuretics.
However, the source states these traditional methods have been generally unsuccessful. It even quotes Hera, stating, "No currently used therapy is efficacious for CRAO," but immediately qualifies this by noting Hera did not consider HBO in that statement, suggesting HBO might be an exception to this historical lack of efficacy.
More recent approaches mentioned include thrombolytic agents to dissolve clots and even surgical removal of the embolus. One study cited reported limited success with thrombolytics used with other therapies. Importantly, improvement was seen only in patients treated within 12 hours, again highlighting the time factor.
Supplemental oxygen has been used alongside these methods. The source underscores that when retinal flow stops, the retina becomes ischemic. Flow might restart via recanalization, but if cell death has already occurred during ischemia, vision may not return even if flow is restored.
Right, the damage is done.
Precisely. This reinforces the concept of irreversible damage and the need to rescue the ischemic penumbra, the threatened but still viable tissue.
The source provides compelling case reports showing oxygen can reverse ischemia, sometimes even at normobaric pressure. One remarkable case involved a patient with CRAO in his only seeing eye, presenting within an hour. His vision was 2400. On 100% oxygen via mask, just 1 ATA, his vision rapidly improved to 20/25.
Wow, that's dramatic.
It is. And when oxygen was removed, it quickly dropped back to 2400. This dependency was confirmed by repeating the cycle.
This patient was hospitalized and maintained on oxygen for 18 hours, after which his central retinal artery presumably recanalized. Crucially, when oxygen was removed then, vision remained stable at 20/25, and he was discharged with excellent vision in his only eye. This case strongly supports the idea that oxygen can sustain tissue viability until flow is restored.
Another report described 2 patients improving on 1 ATA oxygen, even with slight delays, 4 hours and 90 minutes. Again, vision quickly dropped when oxygen was removed early, but recovered when resumed, demonstrating the oxygen dependency before stable recanalization occurred hours later.
The source also discusses carbogen, that's 95% oxygen, 5% carbon dioxide, used in 2 cases with delays over 6 hours. One patient improved from hand motion to 20/20, treated intermittently for 48 hours. The second didn't significantly improve. The rationale for carbon dioxide is to counteract oxygen's vasoconstrictive effect on retinal vessels, theoretically increasing flow.
But does the source think that works?
Well, the source questions carbogen's benefit if oxygen delivery is primarily by diffusion from the choroid, which isn't affected by oxygen tension changes like retinal vessels are. It notes that hyperoxygenation of the choroid likely outweighs any reduced retinal flow from hyperoxia.
And a safety warning.
A critical safety warning about carbogen is provided. Never use it during HBO because elevated choroid significantly increases the risk of CNS, oxygen toxicity, and seizures. Very important point.
A key study highlighted for demonstrating the importance of time is Augsburger and McGargle from 1980, using older therapies including carbogen. Of 34 patients, 12 improved. 7 of those 12 were treated within 24 hours, with the longest successful delay being 72 hours. The average delay for success was 21.1 hours versus 58.6 hours for failure.
That's pretty stark data supporting the time is vision principle.
It really is. A fascinating case report involved combined CRAO and posterior ciliary artery occlusion. The patient had minimal light perception after 5 hours. Despite traditional therapies, including carbogen, his vision didn't improve for 3 days, but then improved spontaneously 96 hours after onset to 2030.
Spontaneous recovery after 96 hours.
Yeah. While authors didn't credit a specific therapy, the source author notes the potential role of oxygen in maintaining viability during that long ischemic period before spontaneous recovery, particularly notable as spontaneous recovery is apparently rare.
The source reinforces that if 1 ATA oxygen isn't effective, emergent compression for HBOs should be done. A case report by Phillips et al. Illustrates this. 1 ATA oxygen didn't restore vision in a patient with 2-hour onset, but light perception returned at just 1.45 ATA during compression.
So vision improved during the pressure increase.
Yes. By the end of the first air break at 2.8 ATA, she had returned to subjective baseline, discharging at 2030 with resolved APD. This shows recovery can happen during compression and at pressures below maximum.
The source strongly emphasizes that timing is critical for HBO. There's a time threshold beyond which ischemic tissue won't recover even with reperfusion, the point where the penumbra is lost. Experimental evidence from monkey studies cited by Hara et al. Suggests this threshold for complete occlusion is between 97 and 105 minutes.
Very short window in that model.
Extremely short. However, the source notes that clinical CRAO often has some residual flow detected by angiography, unlike the animal model. This partial flow might explain the variability in outcomes seen with different treatment delays in humans. The shorter the delay to treatment, the better the chance of rescuing the penumbra.
The ophthalmology literature includes reports of vision regained even with delays up to 2 weeks, though the source clarifies the strongest evidence for symptomatic improvement is in cases with less than 12 hours delay.
Okay, so we have reports of success later, but the best evidence points to under 12 hours, along with the 8-hour and 24-hour windows mentioned elsewhere. It seems the exact window is still debated or varies.
Precisely. There's variability in the literature reported here. Table 1 summarizes the literature on HBO for CRAO. Looking at the aggregate data, the total row at the bottom, it shows 668 improvements out of 1,025 reported cases treated with HBO, yielding an overall improvement rate of 65%. This figure comes directly from the compiled studies in the table.
The table shows a wide variety of protocols and delays across studies, from less than an hour to weeks. It includes studies using HBO alone and in combination with many other therapies, and some older studies just using adjunctive measures. This highlights the historical evolution and variability in treatment approaches.
While difficult to predict individual response, minimizing ischemic time maximizes potential for recovery. Herzog et al. Study of 17 patients treated with HBO noted benefits specifically when treated within the first 8 hours. Their protocol was 105 months at 2 ATA, 3 times daily for 3-4 days or until improvement plateaued.
Reinforcing that tight time window again.
Yes. They used a powerful analogy. Time is muscle. For MIs, time is vision. For CRA, effectively stressing urgency. Another paper showing success with HBOs in patients treated shortly after onset. One treated at 90 mins improved from light perception to counting fingers after 10 mins HBO, then to 20/70 after 5 days of twice daily 2.5 ATA treatments.
Quite specific protocols there.
Another at 40 mins onset went from hand motion to 20/20 at 12 mins at 2.5 ATA. A third at 4 hours onset had gradual improvement to 20/30 over 10 sessions at 2.5 ATA. A patient treated at 6 hours showed no improvement, showing not all respond.
The Baron et al. 2001 retrospective controlled trial is a key piece of evidence cited. It compared 35 CRAO patients treated with HBO to 37 controls, all treated within 8 hours. None had ciliary retinal arteries. The HBO group received 2.8 ATA for 90 minutes twice daily for the first 3 days, then daily.
And the result?
Significant. 82% improvement in the HBO risk group versus 29.7% in controls, with improvement defined as 3 or more lines better on the Snellen chart. Mean final acuity in the HBO group was about 20/70. This controlled study within a tight time window provides strong support for HBR efficacy.
The source concludes that HBOs must start within the viable time window. It critiques negative HBO reports that lack timing info, suggesting delay was the issue. Miak's study of 53 CRA patients found no time-to-treatment correlation with response, but the source explains this likely because only 3 patients were treated within 24 hours. Most were outside the optimal window.
Overall, the 65% improvement rate across studies in Table 1 supports that some patients can be successfully treated with hyperoxia, either at 1 ATA or with HBO, and the sooner the better. The quantitative impact: 0.03 log MR worse visual outcome for each hour of delay.
And a cherry red spot predicts lower likelihood of improvement with HBO, 49% versus 86% without. This reinforces poor prognostic value.
Based on American Heart Association evidence classification, HBO-RO for CRAO is level IB, fair to good evidence from controlled case series, but lacking level 1 randomized controlled trials. The source calls it acceptable, safe, and efficacious, with no evidence of harm and consistent positive results when begun early.
It highlights the lack of alternative therapies with similar outcomes cited. Thus, HBROS is proposed as a standard for a needed randomized controlled trial, acknowledging the rarity of CRAO makes randomized controlled trials difficult.
Despite this evidence supporting early use, the source notes a disconnect. A survey found only 7% of surveyed U.S. centers with vascular neurology and retina or neuro-ophthalmology sometimes offer HBO for CRO.
Only 7%? That's low.
It really is. It points to barriers in utilization despite the available evidence presented here.
We've just completed a thorough evidence review based on this source, discussing animal models, traditional therapies, case reports highlighting both normobaric and hyperbaric oxygen success, including dramatic reversals and recovery during compression, case series emphasizing the 8-hour window and multi-day treatments, and the key BRAN controlled trial showing significant benefit with HBO within 8 hours. We examined the aggregate 65% improvement rate from Table 1, the quantitative impact of delay, the cherry red spot as a negative predictor for HBO response, and the level II evidence grading for HBO, acknowledging the need for level 1 data while supporting its current use due to lack of alternatives and observed early benefit. We also noted the concerning gap between this evidence and reported clinical utilization in some U.S. centers. Utilization review.
Moving to utilization, the source acknowledges that the optimal number of treatments will vary based on symptom severity, duration, and response. Treatment courses are individualized.
The source notes that most patients will stabilize within a few days. Based on this, it recommends utilization review, a reassessment for patients treated for more than 3 days after reaching a clinical plateau with no further visual improvement.
So a checkpoint around day 3 if things aren't changing.
Exactly. It provides a guideline for when to question continued therapy. Useful endpoints for discontinuing supplemental or hyperbaric oxygen are provided. Stabilization of vision on normoxic breathing, so room air, and confirmed central retinal artery patency on fluorescein angiogram. Cost impact.
Regarding cost, the source states there are no formal cost analyses for CRAO in the provided literature.
However, it estimates the direct treatment cost for HBO at $200 to $500 per 90-minute session in an outpatient setting.
If a patient received 10 treatments, the estimated cost would be between $2,000 and $5,000 per patient.
The source offers a value judgment here, stating this is considered a reasonable price to pay to restore a patient's vision, framing it as an investment rather than just an expense.
Furthermore, it emphasizes that the cost of long-term care for someone who has lost useful vision must be considered in the economic impact, highlighting the significant societal cost of permanent blindness as justification for investing in potentially vision-saving therapy like HBO.
Good point. The cost of not treating effectively. Key takeaways.
Let's consolidate the key takeaways the source authors explicitly highlight. First, painless vision loss must be treated as an emergency under a stroke protocol.
Second, supplemental oxygen for CRA should begin as soon as possible. Don't wait.
Third, optimal outcomes are achieved if hyperbaric oxygen is initiated within 12 to 24 hours of symptom onset, presenting that key time window based on the reviewed evidence.
Fourth, based on the aggregate literature in Table 1, Hyperbaric oxygen therapy can improve vision loss in CRAOs 65% of the time.
And fifth, patients with suspected giant cell arteritis require emergent steroids in addition to oxygen therapy. Don't forget the steroids, disclaimer.
And just quickly, as a standard disclaimer from the source document itself, the opinions expressed in this paper are those of the authors and do not necessarily reflect those of the Department of Defense or the Department of the Navy. Outro.
We've just completed an extensive deep dive into central retinal artery occlusion, meticulously dissecting the source material you provided.
We laid the crucial groundwork by reviewing the intricate ocular vascular anatomy, the devastating impact of ischemia on the highly metabolic inner retina, and the compelling physiological rationale for oxygen therapy based on the choroid's ability to supply oxygen under hyperoxic conditions.
We walked through the clinical presentation, the essential multidisciplinary approach involving ophthalmology and neurology as part of a stroke protocol, and the necessary systemic workup to identify underlying causes, while stressing that none of this should delay emergent oxygen treatment.
We spent significant time navigating the detailed management algorithms presented, specifically the sequential escalation of oxygen pressure in hyperbaric therapy from normobaric to 2, 2.4, and 2.8 ATA, using the U.S. Navy Treatment Table 6 protocol. We discussed the different protocols presented for initial and repeat treatments, the importance of treating based on vision response, and the rationale for continuing therapy even without immediate improvement, citing compelling case series data showing delayed responses.
Right, those delayed responses were striking.
They were. We also highlighted the specific indications for intermittent normobaric oxygen and combined regimens, as well as the crucial follow-up algorithm focusing on assessing vision stability off oxygen and managing recurrence with urgent stroke evaluation.
We critically examine the evidence base, from supportive animal models and dramatic case reports showing vision recovery with oxygen, to case series and the Barron-controlled trial showing significant benefit within an 8-hour window. We discussed the variability in reported time windows for success across the literature, the quantitative impact of delay, that 0.03 log MAR penalty per hour, and the negative prognostic sign of a cherry red spot for HBO's response.
We addressed the level II evidence grading, acknowledging the need for higher-level randomized controlled trials while understanding the challenges of studying this rare condition and the rationale for using HBO, given the lack of proven alternatives and observed early benefits. We also noted the concerning disparity between this evidence and reported utilization rates in some centers.
Finally, we touched on practical aspects like utilization review guidelines and the economic considerations, weighing the estimated cost of HBO against the significant societal burden of permanent vision loss. We pulled out the key takeaways emphasized by the source authors, reinforcing the emergent nature, the necessity of immediate oxygen, the optimal 12-24-hour window for HBO, the 65% aggregate improvement rate, and the specific steroid requirement for suspected giant cell arteritis.
For you, as a specialist clinician, this deep dive provides a detailed map of the current understanding and management of CRAO as presented in this specific source. It equips you with the physiological rationale, the specific protocol details, and the evidence base, including its limitations, to help guide your approach to these challenging and time-sensitive cases, emphasizing the potential role of early hyperbaric oxygen therapy compared to historical outcomes.
So, to leave you with a thought building on what we've explored, given the stark contrast between the historical lack of success for untreated or traditionally managed CRAO and the potentially significant improvement rates and rapid vision recovery demonstrated with early oxygen therapy, particularly hyperbaric, in the study cited here, what specific steps can be taken in clinical practice and research to overcome the identified barriers like the limited utilization rates or the difficulty in conducting level 1 trials to ensure that eligible patients have access to this potentially vision-saving treatment within the crucial time window presented in this source?